Hey everybody, this is Michael, and this is going to be your intro to EKG for respiratory care. Specifically here we're targeting our first year students, and this is going to be our introduction mostly into EKG rhythms. We're going to talk somewhat about 12 lead and how to acquire 12 lead and how you're going to essentially do that test, but mostly we're going to talk about how we assess the rhythms and the rhythms that you're going to need to know for your testing, the things you're likely to see on your board exam, and the things you'll need to go to build a foundation to get or to learn 12-lead EKG. Objectives for this are going to be real simple. Not sure how long it's going to be yet. We'll see when we're done. But some basic cardiovascular A&P. We're going to talk a lot about electrode preparation and placement. This is going to be super important, especially when you actually get into doing 12 leads. Talk a little bit about the layout of the EKG paper and the printer and how that all works, because the way that the printer works and the way that you assess the EKG is going to have a lot to do with what it looks like on paper. And so understanding how that paper is laid out and how it interacts with the printer is kind of important. After that, we'll get to some real nuts and bolts about the systematic approach for rhythm analysis. We're going to talk just a little bit about 12 lead here, not a whole lot, mostly about how to do one. But most of this is going to focus on rhythms for you. And then the basic rhythms that you need to know, including sinus dysrhythmias, junctional dysrhythmias, ventricular, atrioventricular blocks, and then a very little bit about pacemaker rhythms at the end. You can't really do anything like this without a little bit of review of anatomy and physiology, and this of course is not going to be exhaustive or dig a hole into your big A&P, but some of the core points about the heart as it relates to the way that we're going to assess it with the EKG. And one of the coolest things about messing with the heart and with that anatomy is that the heart is what I think of as a global organ. It's one of the few things that you can look at and assess both electrically, with ultrasound, with the cath in the cath lab, in a number of different ways. You can assess it from all sides and from all angles, so it really is kind of a global organ. And we're going to look at two specific parts of anatomy for the purpose of this course, and that is we're going to look at the circulatory anatomy of the heart itself, in other words the coronary arteries, and we're going to look at the conduction system. We're not going to get into tracing a drop of blood through the heart and the chambers and valves and all that kind of stuff, because it doesn't have a lot of bearing on what we're doing here. But what does have bearing on what we're going to do here, and will especially have bearing later, is how blood moves to nourish the heart, and then how the electricity moves to make the heart actually pump. So when you look at just a gross global model of the heart, we think of large coronary arteries. And what is important to understand is that those large coronary arteries are very important. And when somebody goes to the cath lab and they have a heart attack, then they're worried about which one of those big arteries are obstructed. What is important for us to remember is, just like every other part of the body, is that the big vessels move the gross amount of blood to and from those areas of the heart, but it's those tiny little vessels, the capillaries and things like that, which actually do the movement of blood through the tissue. And so when you obstruct one big vessel, say you obstruct the right coronary artery, then we can reasonably predict what areas of the heart that's going to feed, but we also have to keep in mind that as those vessels constrict, those capillaries, those capillary beds also become constricted, and we start losing perfusion downstream. And the interesting thing about this, just from a clinical perspective, is that when those beds, those capillary beds, become acidotic, in other words, the pH starts to drop really, really low, and they become anoxic, so they don't have any oxygen anymore, then they constrict. And after about 90 minutes, you get something that's called the no reflow phenomenon. And basically what that means is that those little capillaries are going to constrict, they're going to spasm, and they're never going to open ever again. And so that is why it is so important that when we recognize somebody's having a heart attack, is that we do something about that. because we're rapidly losing time. It's not even as much of the thing you've heard before, I'm sure. Time is muscle, but time truly is vasculature. And if we lose those vessels, then we're never going to get them back. But as we said, we start with those three big coronary arteries. And the first one we're going to look at is our right coronary artery, the RCA. And when I think about 12-lead EKG, everything really kind of goes back to that, because as we assess somebody for occlusive disorders like a STEMI, then we think a lot about what's wrong with the areas which are affected by the vessel. So people tend to think of EKGs or STEMIs in terms of this is an anterior STEMI or a lateral or an inferior or whatever. And I always encourage people to think of it instead as about what vessel is affected. And this can help you predict a little bit better about what's going to be wrong with this patient. And so we think about this from a vascular perspective. We want to think about what each one of these arteries is responsible for feeding. And looking at the RCA, and you see the RCA, our little green stripe down there on the obviously the right side of the heart, traces right beside the right atrium and down the inferior side of the heart and on around to the right ventricle. And it's going to feed a number of different things. In a lot of patients, it's responsible for providing blood flow to the SA and the AV nodes. This will be important later when we talk about bradycardias, because often they have their origin in a problem with the SA or the AV node. Sometimes this can be traced back to an RCA occlusion or some other kind of circulatory abnormality. The RCA is almost exclusively responsible for perfusing the right ventricle. So if you have some kind of right ventricular failure, right ventricular problem, perhaps there's a problem with the RCA. And then it's going to wrap around and supply blood to the posterior side of the left ventricle. That's not in every patient, and that's important to remember, is not all this stuff is the same for every single patient. We think about things about people who are right heart dominant versus left heart dominant. That gets beyond the scope of what this program is meant to teach, but those are important things to know as you get into advanced concepts with EKGs. Is not everybody's right coronary artery is going to supply blood to the same area. Some people have vastly different kinds of circulation. So those things are important. But in most patients, the RCA is going to supply blood around to the SA node, the AV node, the right ventricle, and the posterior side, and of course the inferior side of the left ventricle. That makes that a very predictable pattern. On the left side of the heart, we're going to look at the left main coronary artery. We don't talk about the left main a whole lot by itself because it's not that long. It's only about a centimeter long before it bifurcates into the left anterior descending and left circumflex. And the reason for this bifurcation, this will come up later when we look at the conduction system because it does something very similar, is because there's just a whole lot of muscle mass on the left side of the heart that has to be perfused. And so this is done much more efficiently with more than one vessel, more than one main vessel as they break off from the left main. And we're going to look at each one of these individually. So first we'll look at the LAD, the left anterior descending. You see our little green snake going down the front there, and it's going down the front anterior side of the left ventricle. So that's where it gets left anterior descending. And we talk about what it feeds. It's going to feed most of the anterior wall of the left ventricle with blood. So when you hear somebody talk about having the widowmaker MI, it's usually what they're talking about is a left main or a LAD occlusion, because it really takes out a lot of the pumping mass, and a lot of those patients don't do really well. But it also feeds 2/3 of the septum, and the septum becomes important because there's a lot of pumping or contractile function and a lot of conduction that is housed within the septum, and so maintaining an uninterrupted blood supply there is very important. And that's why that there's another co-circulation actually comes from the RCA, which goes to the septum. Part of that too is the left and right bundle branches and the hemifascicles, which also act as part of the conduction system we'll talk about later. And really just the majority of the pumping mass of the left ventricle is fed by the LAD. So again, if somebody has one of those widowmaker heart attacks, they really don't do well because they lose a lot of their pumping mass, especially if their obstruction in the LAD is way high. The other bifurcation of the left main coronary artery is our left circumflex, or what's often referred to as the LCX. And you can see it here, a little green stripe around the side. And this, of course, is the posterior side of the heart that you're looking at. So just for some reference, over here is the backside of the right coronary artery we talked about a second ago, when it turns from the right coronary artery right here into the posterior descending artery. And this is the AV nodal artery right here that feeds the AV node in most patients. Here is the inferior vena cava, up here is the superior vena cava, the aorta, pulmonary artery, and the pulmonary veins. And the vessels, or the area usually fed by the circumflex vessel, is going to be obviously the upper lateral wall of the left ventricle, the area fed by, or seen by in the EKG by leads V5 and V6. The SA node in about 45% of patients, so slightly less than half. The AV node in about 10% of patients, and this is based on the heart dominance. And then the posterior sides of the left bundle branch and the posterior hemifascicle, which are parts of the left bundle branch. And so that gets again into that, the importance of the co-circulation that perfuses the septum because of how important that is. Now what you're going to notice as we start talking about the conduction system is the conduction system and the circulatory system follow very similar patterns because they have the same jobs, which is provide a valuable service to the heart. So obviously our circulatory system is providing blood and nourishment and nutrition to our heart muscle. For our heart muscle to work, the conduction system has to provide electrical impulse to those areas. So we'll first look at our supraventricular conduction system. And this is what we look at up here with our SA node, our intranodal pathways, which will bring electricity from the SA node down eventually to the AV junction. Bachman's bundle is over here. That's going to innervate the left atrium to make sure that electricity spreads out across the atria at the same speed. And synchronicity is everything when you talk about electricity in the heart. And so one of the reasons we look at rhythms so intently, one of the reasons why we care about rhythms so much that we monitor them at the bedside of almost every patient we have, is because if the heart is not in sync, if it's not properly synchronized in the way it conducts electricity from the atria down through the AV junction into the ventricles, then it's not going to pump blood effectively. Now, just for some context, this is a cross-section of a atrium. It's actually a pig atrium. I cut it myself. And up there with the label you see is the SA node. And then tiny little white fibers you see here, that's the actual intranodal pathways. And if you were to follow this further down with a further cross-section, you would eventually get down to the AV junction at the top of the ventricles. So you can see how tiny this little node is, but also how important it is, because when we talk about dysrhythmias, one of the first ones we're going to talk about is all the things that can go wrong with the SA node. Either it fires too fast, too slow, out of sync, or doesn't fire at all, which forces the rest of the heart to kind of take up its slack. Moving further down into the ventricular conduction system, we have the bundle of His. Now, the bundle of His is analogous to the left main coronary artery. It's also very short, about a centimeter long. And it immediately bifurcates, just like the left coronary artery, into two other smaller branches, in this case, the left bundle branch and the right bundle branch. The left bundle branch is going to bifurcate even further into the anterior and posterior hemifascicles, and that's going to make up what we call the trifascicular system, which is responsible for conducting electricity throughout that whole big ventricular muscle mass at the same time, so that those ventricles contract at the same time. The way that electricity gets from those bundle branches all the way down into the deepest parts of the heart muscle is through the tiny little fibers known as Purkinje fibers. Here we see the same big heart cut over. This is a bottom part of the ventricles, and all those little white squiggles there that you see, those are the Purkinje fibers. They are carrying that impulse from the larger wires, the bundle branches, down into the smaller areas of the heart where they can reach the individual myocytes that can be polarized or depolarized rather. They can contract and contract all at the same time together to result in a crisp, synchronized contraction, which will pump blood out to the body. Now, one of the more important things that you take away from the conduction system is just how fast it conducts. And so the most useful clinical thing from that is how fast the heart beats. And this is directly related to which part of the heart is driving that conduction or depolarization. And it's really just a matter of which one of these areas depolarizes first, and that's going to give your heart rate. We know our normal heart rate is between 60 to 100. A normal sinus rhythm is between 60 and 100. And that comes from the sinoatrial node, the SA node. Its intrinsic firing rate by its rate of depolarization is 60 to 100. It gets to be first because it depolarizes first. If it fails to depolarize fast enough, in other words, less than about 40, then usually the AV junction is going to take over. Its intrinsic rate is 40 to 60. If it fails to depolarize fast enough, then the bundle branches will kick in at a rate of 30 to 40. And then lastly, the Purkinje fibers can take over as the pacemaker of the heart at a rate of 20 to 40. So whichever one of these goes fastest gets to be the pacemaker, typically that being the SA node. But it's important you know all these intrinsic rates, because that's going to show up in board exams and other tests that you're going to take. It's also going to be a foundation for how you treat these rhythms later when you talk about things like ACLS. So, now that we've talked a little bit about our anatomy, we then need to know how to best assess the heart based on those things, and that gets us into how we actually do the 12-lead EKG. Now, the first thing I want to explain is that what we're going to talk about here, our electrode placement here, is we're talking about how to do a 12-lead. That's a diagnostic procedure. And our diagnostic procedure is going to be how we assess things, not only like rate and rhythm, but how we're also going to assess things like ST elevation, ST depression, QT intervals, and things like that. If you just want to assess rate and rhythm and that's all, then the bedside monitors we use with the electrode stuck on people's chest is usually fine. All we need to see then is a QRS complex to be able to see what the heart rate is and then what the rhythm is. If you want to actually do some diagnostics, then you're going to need to do a 12-lead, and that's what we're talking about here. So the first thing we have to do when we think about doing an EKG is it's a whole different setup from just putting on somebody on the monitor just at the bedside. And one of the first things is how you're going to position the patient. And positioning the patient, supine position is really the best. Now, I have to confess, I've never taken a patient who was sitting up and laid them flat to do an EKG, and most people, other people I talk to, haven't either. But the only reason we talk about supine position is because laying flat will help the patient to be still, which is important. So it's going to decrease the artifact. And artifact is just extra squiggles you get in the tracing from somebody moving around. And it's also going to improve your accuracy. If you can't get somebody laying flat, and usually you're not going to, somewhere in the neighborhood of 30 to 45 degrees head of bed up is perfectly fine. But the biggest thing there is you get them to lay still. The next thing you want, and this is more important than a lot of people make it, is you want their skin to be bald. So, and this obviously is much more important with men because they tend to have more chest hair than women. So if you have less hair or no hair on the skin, the electrodes tend to stick better. They also tend to touch skin better and stay on better. So if you look at somebody like this, I'm not hating on people with chest hair. I mean, if I take off my shirt, I look like I'm wearing a sweater. I get it. But if you stick electrodes on this guy's chest hair, they're not going to be touching his skin, and you're not going to get a good electrical signal. And it's not uncommon that we'll see patients with something like this. We'll walk in to get their EKG, and their electrodes look something like this, just kind of floating on a sea of chest hair, and that's not really doing you any good. You got to get that hair out of the way. Now, you can do this a number of different ways. You can shave the whole chest, which takes a minute, maybe not the best idea. You can shave out places just for those individual electrodes to go. It doesn't really matter as long as you get the areas that you need to shave down where those electrodes are actually touching skin, because that's really, really important. The next thing is the skin needs to be a little rough. This is a very often overlooked step, is that you need to somewhat abrade the skin. So this allows the electrodes to stick a little better, and it gets some of that dead skin out of the way. We are all covered in 2 layers of dead skin cells. The only place in your body not covered in dead skin is your lips and the corneas of your eyes. Everywhere else has got the external layers of dead skin. You got to get some of that out of the way, because dead skin, especially in excess, will cause a deviation of electrical current and will give you some false readings. So when you look at your normal EKG electrode, this is just a simple old snap-on electrode. And when you turn those over, on the back of those, they tend to have these little raised dot areas up here. And those things are actually there to help you abrade the skin a little bit. Some of the older electrodes actually had little pieces of sandpaper there. Some of the newer alligator clip electrodes, like the hospital machines use, have strips of sandpaper between the electrode rows in the pack. They're all for the same thing, to kind of abrade that skin and get rid of some of that dead skin. Some places, this is pretty mostly seen in EMS agencies, they'll carry those little green scrubby pads you can get from the store for like, $100 for $1 or something. And they'll cut up little strips of these, keep in their EKG kits, and use those to get for their abrasive quality. And finally, and this kind of seems like a no-brainer, but you always got to say it, is the skin has to be dry. This will help the electrodes stick. It'll help for conduction. It'll help for durability of those electrodes sticking to the skin. And when you ask for, what helps skin dry the best, I hear all kinds of stuff. I've heard agencies that carry deodorant or antiperspirant spray or stuff like that, all kinds of stuff. Honestly, the best thing to dry wet skin is a towel. And if you happen to use hospital towels, as most of us do, they tend to be pretty abrasive. And so you can use a hospital towel to dry the skin, kind of abrade the skin, and clear away that hair that you trim, so you can kind of do a all-in-one step there for getting a good quality EKG. So once you prep the skin, now you actually have to put the stickers on. And to do a 12-lead EKG, to get 12 leads, that takes 10 electrodes. And where you put every single one of those is absolutely crucial to get useful results. This is going to vary a lot depending on the facility you go to work in or do your clinicals in. This is going to vary a lot depending on what you read. But the science is pretty clear on where these things need to go. And so I would always begin with starting the exact right way and then kind of adapt your practice depending on where you are. Another important thing too is that whenever you put electrodes on, that you put them on in the same place somebody put them before, so you get consistent exams. But in order to think about where these electrodes go, we're going to start with the limb leads first. So our limb leads are leads 1, 2, and 3. They're going to be in that first column on the paper. And leads 1, 2, and 3 are based on the general electrical signal in the body, so where these things come from. So leads 1, 2, and 3 are derived from the right arm, and left leg electrode. Color speaking, these are the right arm is a white electrode usually, the left arm is the black one, and the left leg is the red one. Now that leaves out that pesky green one. What do you do with the green electrode? The green electrode is often referred to as the ground, green for grass or green for ground, and that's almost right, and for the purpose of this discussion it's right enough. But what it does is it kind of helps you take out the electrical garbage. It acts as a neutral recording point for all the other electrodes. And so you'll notice most modern cardiac monitors, whether you're talking about monitors or 12-lead machines, will not function. They won't read anything if you don't have that right leg electrode stuck on somewhere. But for the purposes of individual leads, the right leg electrode isn't figured into any of the individual leads by themselves. In other words, you don't get any electrical data on your 12-lead or on your EKG strip from the right leg. So if you take that one out, the machine really sees you as the patient as a triangle. Right arm, left arm, and leg. In this case, it's left leg. As a matter of trivia, if you reverse the right arm and left arm electrode, that's going to cause serious problems in your EKG. It's going to essentially reverse the limb leads, and it's going to look terrible. But if you reverse the left leg and the right leg electrode, the machine doesn't know the difference. You'll never see that. Now, I'm not telling you to do that. I'm just telling you that the machine's not going to kick up a fuss the way it would if you reverse the right arm and left arm. But if you look at your body or the patient's body in terms of this triangle, right arm, and left leg, or just leg, then we can kind of plot out where these leads go. So lead 1 is up there at the top between the right arm and the left arm. Lead 2 is between the right arm and the left leg. And lead 3 is between the left arm and the left leg. And you can see this kind of forms a triangle. Well, that triangle has a name. And its name is Einthoven's triangle, named after Dr. Abraham Einthoven, who won the Nobel Peace Prize, or rather the Nobel Prize for Medicine in 1929, for making the EKG clinically relevant. And he was able to do so by figuring out some very important physiologic and physically important things about the way that your heart puts out this electricity and the way that we can assess it externally. And he understood also that this is based on monitoring that from very specific points on your body. And how we relate that is where we put our electrodes. Now understand that throughout the rest of the presentation, I may use the word electrode and lead interchangeably, but understand that electrode is the physical place from which you are gathering this information, so it's going to be where you put your little sticker. Whereas the lead is the information that you assess on the printed EKG or on the screen that you're looking at. So lead 1, lead 2, things like that come from a certain set or a certain single electrode. When we look at our limb electrode placement, our arm electrodes, so our right arm and left arm, our white and black electrodes, need to go distal to the acromion process down to the fingertips. So anywhere basically between the point of your shoulder and all the way down to your fingertips is an appropriate placement for your arm electrodes. And I typically like to put them where you see in the screen there, down near the wrist. I do that for a couple of reasons. Usually people's wrists are much more accessible than their shoulders or their chest. And most people on the inner aspect of their wrist tend to be hairless, so they don't have to do a whole lot of prep there. And if you tell somebody to lay still, they'll put their arms down by their side, and that becomes a fairly stable recording point. Leg electrodes need to be anywhere from the distal to the inguinal ligament all the way down to your toes. Your inguinal ligament is basically your groin, so it's the ligament that would cause you to adduct or bring in your hip all the way down to your toes. Again, I favor where you see the electrodes in the picture, the red one and the green one, mostly because somebody that wears socks with any regularity, those areas are going to be hairless, and so again, they don't typically need a whole lot of prep, and it's also easy to get to somebody's ankles. If you'll notice, most modern EKG machines, the red and green wire are twice as long as the black and white wire because they are made to go twice as far away. They're made to go all the way down somewhere on the legs. A lot of textbooks and a lot of professional guidance will tell you that it's okay to put those electrodes on the abdomen or the lower chest. I'm not going to argue with that, but I will say there's a number of academic studies that have pointed out that you get better results and more consistent results the further away from the heart and the further away from the electrodes you put those two stickers. And they are essential for maintaining things like the axis measurement and things like that. So I would go with whatever guidance you get in class, but I'm going to tell you that from my own personal experience, my own personal research, that put those things far down on the legs is better off. That brings us next to the chest electrodes, or the precordial. And that's really what precordial means, is chest. So the precordial lead placement, this is leads V1 through V6, and those leads are going to be labeled accordingly. So each one of these has a very specific point, either based on anatomy or based on the placement of other electrodes. So V1 and V2, and these are probably the most important ones, because where you place a lot of the rest of these stickers is going to be based on where you put V1 and V2. V1 and V2 go at the fourth intercostal space parasternally. So V1 is going to go at the right sternal border at the fourth intercostal space. V2 is going to go at the fourth intercostal space at the left sternal border. So they'll end up being side by side. So here we see a patient with exposed ribs, which I hope you never see or have to do an EKG on. You'll see kind of where these things are going to be. So they're going to be just above the nipple line in most people. Now, the nipple line can be a moving target, especially as people gain weight or they get older. So that's why we don't use the nipple line as a decent landmark for these. But typically, just below the angle of the sternum, you'll be able to find where these things go. V3 needs to go halfway between V2 and V4, so we have to find where V4 is. V4 is going to go at the fifth intercostal space at the mid-clavicular line. So a lot of people, when they put them on, they'll put on V1, V2, V4, and then go back and place V3, since now they have a landmark for it. As you gain more experience, you'll just be able to know where this is. V5 and V6 follow in the same straight line as V4. V5 goes to the anterior axillary line, so at the forward crease of the armpit at that same level as V4. And then V6 is in the same line, so a straight line around the side, at the mid-axillary line, so it kind of go under the arm. So in here you kind of see a picture of where those are going to go. Practically speaking, this is probably the best landmark I've ever heard looking at this. So here we see a patient who actually has skin on his chest, which is going to be much more common in your patients. Is we will pull up his picture, and you'll see right here the 4, 5, and 6 are right at what we call the inframammary fold. So even though the nipple line will move as somebody gains weight or gets older, the connection or the actual attachment from the breast tissue to the chest wall typically stays the same. It doesn't move a whole lot. And that's called the inframammary fold. And the inframammary fold is your landmark for leads 4, V4, V5, and V6. So it's going to follow right along this straight line. So that's what you need to be looking for. So now that you know how to do the EKG, how to put the electrodes where they need to go, you need to kind of know what you're looking at when it comes out. And this is based on some very standard things, which really haven't changed a lot in medicine over the years. First, the most important rule is that if you want to truly assess somebody's rate, rhythm, their intervals, especially things like ST elevation, ST depression, stuff like that, you have to hold the EKG in your hand. It has to print. And the reason why this is true is because a lot of times those bedside monitors and those electronic screens, those things are compressed for time. So you'll see this whether you're looking at EKG or end-tidal CO2 or pulse ox or whatever. Whereas the paper that comes out of the monitor, comes out of the printer, comes out at a very specific rate of speed, and that rate of speed is 25 millimeters per second. Every single thing I'm about to tell you about what the little boxes and big boxes mean and what all the intervals mean and all these time intervals is based on the fact that the paper comes out of the printer at 25 millimeters per second. The only time you'll see a deviation from this is every now and then, like in the neonatal ICU, if they have a kid in atrial fib or an SVT or something like that, whose heart rate is 300 or more. And sometimes they'll need to do an assessment of that to find out if that heart rate is regular or irregular. And I will tell you right now that everything at 300 beats per minute looks regular to the untrained eye. Sometimes what they'll do is they'll take that paper or that printer and they will speed it up. They'll make the printer come out, or the printer print twice as fast. When they make it print twice as fast, it makes the QRS complexes twice as far apart. And when they do that, they're able to assess the rhythm a little better. That's about the only time you'll ever see that. Otherwise, standard paper speed is 25 millimeters per second. So if we take that further to look at the standard paper, and when you get a chance to look at EKG paper, whether you're talking about the big sheets of EKG paper like you'll see in the hospitals, or the smaller strips like come out of the bedside monitors or EMS monitors, these measurements are going to be the same. First important thing about the paper is on the vertical axis, you're measuring voltage. So you're measuring things like ST elevation, ST depression, QRS, amplitude, stuff like that. That is all measured in voltage. And so that's what you're looking at on the vertical. On the horizontal, that's measuring time. And that's what we're really going to focus on here when we're talking about rhythms is time. So when we're counting somebody's heart rate is obviously beats per minute. It's a function of time. If you're looking at somebody's PR interval, that is duration of the atrial conduction in a function of time. QRS duration is a function of time. And so we're really focused on how those things equate to time. So if you look at the standard paper, and you really have two things that you look at. You have big blocks and little blocks. So the big block here is the darker red line. And inside of that you have smaller blocks. And each one of these things is a known amount of voltage and time, again based on how fast that paper comes out of the machine. So each one of the small blocks on the vertical axis equates to 1 millimeter. So it's 1 millimeter of length. Now that's going to equate to a voltage of 0.1 milliamp, which is not going to be important to what we're talking about here. That will be very important when you think about people who are having ST elevation MIs. On the horizontal, that same small block is 0.04 seconds or 40 milliseconds. That'll be important when you're talking about things like PR interval, QRS duration, and QT interval, also in how we're going to calculate our heart rate. So obviously if one small block is 0.04 seconds and there are 5 of those inside of each one big block, then one big block is going to be 0.2 seconds or 200 milliseconds. And that'll be especially important again when you calculate those intervals or heart rate. And then one of those big blocks, tall or on the vertical axis, that is 5 millimeters or 0.5 millivolts. And again, I think I said milliamps earlier, it's actually millivolts. Whenever you calculate things like ST elevation, ST depression, QRS amplitude, stuff like that, that's where that's really going to become important. But that's again beyond the scope of what we're talking about here. So as you talk about looking at the paper, then you have to figure out actually what you're measuring. So what you're measuring is the QRS complex and all these waves and durations and things like that as they relate to things like the heart rate, so on and so forth. So we first look at our P wave. So our P wave represents atrial depolarization. So anytime you hear depolarization in terms of EKG, you should think contraction. So what the P wave should represent electrically is contraction of the atria. Now the P wave can be upright, inverted, biphasic, means it can go up and down, or it can just not be there. Either of those is possible. The QRS complex, or the Q wave rather, here represents ventricular septal depolarization. So again, contraction. Now the important thing about the Q wave is Q waves are always negative. They always occur below the isoelectric line. So if you see somebody talking about Q waves, that's always going to be a negative deflection below the isoelectric line. And when you think about a Q wave in terms of the QRS QRS complex. The QRS complex is this whole thing. Now, the QRS complex is not always going to have every single wave. It's not always going to have every single Q, R, and S wave. Some leads you don't want that. Some leads it's not normal. But all those things relate to depolarization of the ventricular system. So Q wave is going to be negative. The R wave is the first positive deflection after the Q wave. So R waves are always positive. And some leads there aren't going to be any R waves. But if there are they're always going to be positive. The S wave is always going to be negative. It's always going to be below the isoelectric line. So that's why they talk about the QRS complex, and they call it that even if all those waves aren't there. And all of those things represent ventricular depolarization or ventricular contraction. The T wave represents ventricular repolarization. So when you hear repolarization, you should be thinking the term rest, because that's the time that that area of the heart, in this case the ventricles, is preparing for the next contraction. So T waves can be, just like P waves, can be upright, inverted, biphasic, or very small to the point of appearing absent, but they have to be there even if they look really, really tiny. So when we look at the QRS complex on top of the EKG paper, we can now use what we know to measure all of these things. And every one of these intervals, every one of these waves has relevance in terms of how big they are or how long they are. So in terms of those waves and intervals, we have to consider those against the backdrop of normal. And that's what we're going to think about as we go forward and talk about each one of those. So we talked earlier about the heart rate being normal at 60 to 100. That's normal sinus rhythm. So we'll be able to count that. And now we can add a couple things to that, which is our PR interval, the duration of time between our P wave and our R wave, and our QRS interval, how wide the QRS complex is in total, which each one of those represent. So our normal heart rate, 60 to 100, our normal PR interval is 0.12 to 0.2 seconds, or 120 to 200 milliseconds. And our QRS complex is 0.04 to 0.12 seconds, or 40 to 120 milliseconds. And if those things fall out of range, that means something very specific diagnostically, which we'll be able to talk about and we'll cover when we talk about the different dysrhythmias. So the first thing, and probably the most important thing you'll do when it comes to the rhythm, is calculate the heart rate, how fast the rate is. Probably the easiest way to do this, and one of the ways you'll see mostly in testing, is using the 6-second strip. So a 6-second strip of EKG, so that's printed EKG, that's important. 6 seconds of EKG strip based on our standard paper speed will come out to 30 big blocks, 30 of the big darker colored blocks on the paper that you look at. And basically what you're going to do is count the number of QRS complexes in that 6-second strip. And since there are 10 6-second intervals in a minute, what you're going to multiply is the number of QRS complexes you count, multiply that times 10, that's going to give you what your heart rate is. So if we look here at the example on the screen, we have a 6-second strip, so there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18 QRS complexes within this 6-second strip. 18 times 10 will give us a heart rate of 180. Obviously that's not normal, but the point is you can easily and quickly count that heart rate. Now, the problem is what happens if you don't have 6 seconds of strip. Another way we can do this is take our R to R interval, so the space between our R waves, one R wave to the next, in millimeters, and divide 1500 by that number. We get 1500 from the number of small blocks per minute of EKG paper speed. And so if you look at this example here, we have 1, 2, 3, 4, 5, 6, 7, 8 millimeters of R to R interval. So we divide 1500 by 8, and that's going to give us about 185 for our heart rate, which is pretty close. Another way you can also do this is that for each large block between R to R, you can multiply that up. So if there is one large block between R waves, that's a heart rate of about 300. And you can double that for every large block after that. So if it's 2, it goes from 300 down to 150. If there's 3, that goes from 150 down to 75, so on and so forth. And that's a good way to spot it. Probably the best way is the 6-second method, or you can just count it out. But those are good ways to figure out the heart rate. Looking at the intervals, the two big intervals we're going to talk about here is our PR interval, which is the distance from the beginning of the P wave to the beginning of the QRS complex, and the QRS duration, which is the duration from the beginning of the Q wave all the way to the end of the S wave, and also the QT interval, which we'll talk about a tiny bit. The PR interval is from the beginning of the P wave to the beginning of the R wave, and this represents conduction speed from the SA node through the AV junction, basically to the bundle of His. Normally that should be somewhere about 120 to 200 milliseconds, or 0.12 to 0.2 seconds. If it's longer than that, then that is most likely some kind of heart block. When we talk about AV blocks later in the show, we'll talk about what that really looks like. But what that tells you clinically is that the impulse is being slowed down irregularly or in an unusual fashion in the actual AV junction. And so that leaves more time for there to be dysrhythmias, which can cause serious heart problems. And this is going to throw the heart out of sync. The QRS duration is the representation of time from the bundle of His all the way through the ventricular system. And this should be pretty fast. This should be 0.04 to 0.12 seconds. So 40 milliseconds to 120 milliseconds. And if it's longer than that, then that signals prolonged depolarization. And what that means is it's taking longer for the impulse to get through all the ventricles to produce that good synchronized ventricular contraction, which will pump blood evenly and predictably. And so when you see long QRS complexes or long QRS interval, what that's telling you is you have prolonged depolarization. The QT interval is one of the least talked about parts of this, and it's actually pretty important. And it represents the entirety of the ventricular cycle. So it starts from the beginning of the S wave, or the Q wave rather, all the way through the end of the T wave. So it covers ventricular depolarization and repolarization. And in order for it to be clinically relevant, you have to correct it for the rate. We're not going to get into that. But understand that the longer the QT interval gets, then the more likely you are to have malignant rhythms, which can get in there and cause the patient to go into VFib or VTAC. That's very hard to get them out of. There's a lot of medicines that cause this to happen. There's a lot of conditions that cause this to happen. It's one of those things that as you get sicker patients who are on more and more medicine, we have to pay really, really close attention to. So we really watch the QT interval closely with some of the interventions we do. And it's one of the things that's going to print on your EKG paper when you're looking at that, in addition to things like ST elevation and depression. So that brings us to the important part, which is actually how to assess and analyze the rhythms. Most important thing about this is that you have to have a systematic way to do it. In other words, you need to look at rhythms the same way every single time. As you do this for testing, this becomes important because a lot of these rhythms will look the same until you go through this process and dig into them a little deeper. Clinically speaking, as you start doing this, it's really important that you don't get tunnel vision on one really ugly thing about a heart rhythm, with really big ST elevation or really tachycardic or whatever, and that every single time that you're doing this, you're going through this little process to make sure that you're seeing everything about their rhythm you need to. So I always advocate that people go through this the same way every single time. The best way I found to do that is, first of all, count the rate, see if it's tachycardic, bradycardic, or normal. Then look at the QRS complex, see if it's wide or narrow, because that's going to kind of point you to where the origin of this rhythm is. See if it's regular or irregular. There's only one rhythm that's going to be grossly irregular all of the time. Everything else is going to be mostly regular, and that's going to help you find the patterns. Find the P wave, that there, first of all, is a P wave. If there's not, look for a flutter wave or a fibrillation wave, or none of those, because that's going to help you name it when you get there. Look at the PR interval. If there's a P wave, then measure the PR interval that comes from it, because that's going to help you diagnose things like heart blocks. Doing all those things will help you figure out where that rhythm came from. Did it come from the atria, the junction, the ventricles, or wherever? And once you do all that, then you can name the rhythm. And again, by doing those things stepwise every single time, that's going to go a long way to helping you figure out what these rhythms are without doing a whole lot of guessing, without getting distracted. So the first thing that we're going to do is look at sinus rhythms. So sinus rhythms, they get their name from their origination in the SA, or the sinoatrial node, sinus rhythms. They almost always have rounded, upright P waves in lead 2. And most of this rhythm analysis we're going to do is going to be based on lead 2. The only reason we do it based on lead 2 is because, first of all, almost every monitor you ever look at in your life is going to be in lead 2. And the reason why that is because lead 2, if you remember from our discussion about where our leads are looking at, lead 2 is a fairly good representation of electrical conduction from the SA node through the AV junction through the ventricle. So it's going to go from top right to bottom left, which is the way that most of our cardiac conduction works. That's why most people put their monitors in lead 2. It's not always right. There's plenty of times when that's not right, but that's what we're going to deal with here. But in sinus rhythms, we're going to have a rounded upright P wave in lead 2. Most sinus rhythms are going to be regular, unless they're not. They will have short PR intervals, unless they don't. In that case, they're probably going to be heart blocks. Their QRS complexes are going to be of normal duration. And most of the variability you're going to have in sinus rhythms is going to be based on their rate. So they're going to be too fast, too slow, or some combination of the two. So everything begins with normal, and that is especially true when you're talking about EKG rhythm analysis. So we'll start with normal sinus rhythm. Normal sinus rhythm is exactly what it sounds like. It is completely normal. And the first thing that starts with is a normal heart rate. So we discussed earlier, normal heart rate is 60 to 100 beats per minute. So normal sinus rhythm originating in the SA node, the sinoatrial node, is also going to be of normal rate at 60 to 100. QRS duration is going to be narrow at 0.04 to 0.12 seconds. The rhythm should be grossly regular, and you'll have a rounded, upright, perfect P wave before every QRS. Now there's going to be some variability to this, but you shouldn't get too hung up on things looking different. Just go by the criteria. And the PR interval is going to be normal at 0.12 to 0.2 seconds. So as I said when we started, most of the variability you're going to see in sinus rhythms comes from the rate. So it's either going to be of normal rate, too fast, or too slow. So in the case of a slow rate, that is sinus bradycardia. So anytime you hear the word Brady, that's going to mean slow. So the only big difference in this and other sinus rhythms is the rate is going to be less than 60. Everything else should be pretty much the same. The QRS is going to be narrow, a normal duration. The rhythm's still going to be regular. The P waves are still going to be rounded, upright, and present for every QRS, and the PR interval is still going to be normal. It's just going to be slow. Typically, treatment for sinus bradycardia is going to be related to the cause. Some of those are cardiac related, where it's going to need a antidysrhythmic or a sympathomimetic like atropine or epinephrine. Other times it may be related to something else that's going on. Sinus tachycardia, by contrast, is going to be fast. Anytime you hear tachy, that's going to mean fast. So the rate is going to be greater than 101. Typically for sinus tachycardias, the rate's going to be less than 150, so it's going to be somewhere between 100 and 150. Usually greater than 150 is going to be indicative of something like atrial tachycardia, which we'll talk about momentarily, or VTAC or atrial fib or something like that. Otherwise, this is going to be still normal. The QRS is going to be normal duration, the rhythm's going to be regular, and you're going to have a round upright P wave for every QRS complex in lead 2. And your PR interval is also going to be normal duration. The treatment for sinus tach is often supportive and it's usually something else causing it. So the most common causes for sinus tachycardia are anxiety, pain, and fever. Secondarily, sinus tach is an early indicator of shock or hypovolemia as people's heart rates elevate, especially in kids. As they become hypovolemic, their rate's going to go way, way up. So the treatment for that is often supportive. Sinus tachycardia is almost never cardiac in origin, and it almost never requires a cardiac intervention like drugs or anything like that. You're usually treating whatever is causing that patient to have that secondary tachycardia, like the pain, the anxiety, or the fever. Sinus arrhythmia is a pretty quirky one, and typically only see it in an academic sense for testing purposes. But it is usually completely normal except for it has an irregular rhythm, which is usually related to the respiratory cycle. So you can see the example we have down here. We've got these little black bars on where you see it gets longer and shorter and longer and shorter. But otherwise, everything else is the same. The QRS duration is normal. The P waves are rounded upright and present for every QRS, and the PR interval is normal. This requires no intervention. Matter of fact, most people probably have this, so it's just not that big of a deal. Sinus arrest is also a rather academic, quirky kind of thing. You don't see it very much. And it is also otherwise completely normal rate, QRS duration, regular P waves, and regular PR interval, except for every now and then you will miss a complete heartbeat. So in other words, no P wave, no QRS, no T wave, none of that. It just has a big hole in it. Again, pretty rare, pretty uncommon, and also pretty benign. Usually doesn't mean anything unless somebody has it in the conjunction or in conjunction with some variable degree of heart block, which we'll talk about later. But otherwise, again, you may see this on a test, you may not, but it's just something to know about. So to review sinus rhythms, they originate in the SA node most of the time, so they're going to have a normal duration of QRS, 0.04 to 0.12 seconds. The rhythm is going to be regular, except for those isolated cases where it's going to be regularly irregular or predictably irregular. They will have rounded upright P waves in lead 2 for every QRS complex. The PR interval is going to be normal at 0.12 to 0.2 seconds, and their variability is going to occur according to their rate, so tachycardia, bradycardia, and so forth. Now, atrial rhythms are somewhat of an offshoot or a secondary thing to sinus rhythms, is that they originate above the ventricles, but not necessarily in the SA node. So they're going to come anywhere from in the atria all the way down to the AV junction. Because of that, their QRS is still going to be relatively normal. So you're not going to see wide QRSs until you get down into the ventricles usually. So the QRS duration is going to be normal, 0.04 to 0.12 seconds. The rhythms are going to be variable, and they're going to vary a little bit more than the sinus rhythms did based on conduction, based on heart rate, and things like that. The P waves are going to look a lot different. So they may be biphasic, which means they go up and down, so above and below the baseline. They may be completely inverted, or they may be completely absent, or so tiny you can't see them. The PR interval is going to be variable, again, based on the conduction and some other factors. And what you call them is going to vary based on their rate. So the first one, again, another rather academic, quirky kind of thing, is the wandering atrial pacemaker. Typically the rate for this is going to be normal, as the QRS duration will also be normal. It'll be mostly regular unless there's some kind of odd conduction thing. But the thing you're going to see here is the P waves are going to alter from beat to beat. They will usually be there. The PR interval will usually be normal, but the P waves are going to look different from beat to beat. So you can see this one is upright, fairly rounded. There's not one here at all. This one is inverted. This one is inverted. This one is inverted, and so on. So it's going to kind of change based on which area of the atria is able to depolarize faster and drive the heart rate. Typically, this also requires no treatment. It's just something to monitor, and this may be an indication of ongoing disease. So if somebody has, extensive cardiac history, then their physician may be following this and may see this as an indication their disease is getting worse. But as far as acute treatment, it typically requires none. Premature atrial contractions, or PACs. This is an addition to the underlying rhythm. So we're going to have to talk about this in terms of what the underlying rhythm is, which we're going to assume it's going to be a sinus rhythm. And then the PAC on top of that. So from the strip we have here, here's our underlying sinus beat, here's another underlying sinus beat, and then right here is a PAC. So it's an additional early atrial beat that did not come from the sinus node. So the underlying rhythm for this is usually going to be regular, and that QRS is going to be normal. Where that's going to change is when you see that PAC, which is going to make the rhythm at least temporarily irregular. Then it's going to go right back to its regularity. That beat, the additional beat, is typically going to be narrow, just like the underlying rhythm, because it's coming from almost the same place. And the PR interval for an underlying rhythm is going to be normal. There may not be a P wave on that extra beat. There may be, it's hard to say. But if it is there, it is usually a normally conducted PR interval. These also require no treatment. What these are telling you, though, is that there's some irritable place inside the atria, maybe more than one, which maybe is not getting enough oxygen, or it has a little disease or something like that. And so these may be an early warning that somebody has some kind of conduction problem or ischemic problem, but it's not typically acute and doesn't require any treatment by itself. Now, there are a lot of different names for this rhythm. Atrial tachycardia, SVT, which is supraventricular tachycardia. You'll see it abbreviated sometimes as PSVT, which is paroxysmal supraventricular tachycardia, and all paroxysmal means is it comes and it goes. But the bottom line for this is a tachycardia that is narrow, that does not originate from the SA node, so it's not a sinus tachycardia. So as we use our systematic approach to dealing with this, we'll look at our rate, which is going to be greater than 101 because it is tachycardic, and it's usually going to be greater than 150. Now that's not ironclad, but usually greater than 150, which is one way that it sets it apart from sinus tach. The QRS duration is going to be narrow because it comes from above the ventricle, so usually 0.04 to 0.12 seconds. The rhythm is going to be regular, and that's going to be important when you compare this to things like atrial fib, which is not going to be regular. So this, within the rhythm itself, is going to be pretty regular. And then if you can see P waves, they're going to be odd looking, so biphasic, inverted, or usually they're absent. Usually you can't see them. In our example down here, you maybe can imagine a P wave here and there, but otherwise it looks like they probably aren't there. And if the PR is there, then it's going to be variable depending on where that P wave is. But usually these rates are going to be kind of fast, and you're not going to see P waves at all. It is not uncommon to see SVT rates that get up close to 300 beats per minute, even in adults. And just as some trivia, and clinically speaking, one of the ways that you can differentiate a tachycardia like this from, say, a sinus tachycardia is typically if somebody with sinus tachycardia, if you sit them up, so say they're laying flat and you sit them up, their heart rate will typically go up. So it will go up to compensate. When you lay them flat, then it usually goes back down. Atrial tachycardias, SVTs, are typically not like that. Usually if somebody has a heart rate of, say, if they're sitting up and their heart rate is, say, 240, and you lay them flat, their heart rate's going to stay 240. They're not responsive to that kind of thing. They require more treatment. And the treatment they require is going to be based on the severity of their symptoms. So if somebody is stable, and we'll use this distinction several times as we talk through the rest of these rhythms. If somebody is stable, and what stable usually means is two things. The first thing I always look at is mental status. If somebody is awake and alert, and they can answer your questions, they are typically stable. Now that's not, again, it's not guaranteed. None of this is guaranteed. None of this is every time it's true. But if they're awake and alert, usually they're fairly stable, and if they have reasonably stable vital signs. So if you can feel a radial pulse and they have a decent blood pressure, we can typically call them stable. They get unstable when their mental status starts to fail and we start losing things like blood pressure. They become tachypnic, they complain of chest pain or shortness of breath, things like that. If they are stable, we typically will either do nothing or we will cardiovert them with medication. So there are several different drugs which are useful for treating this. So things like, you will hear words like adenosine and cardizem and Lopressor or metoprolol are medications that they sometimes use to treat these patients who are stable. If they have known underlying disease, and this is a common thing for them, sometimes they won't do anything until they get to the hospital. It's not uncommon for people to be in one of these rhythms for a couple of days before they get cardioverted to see if they'll come out of it themselves. If somebody is unstable, in other words, they have those symptoms, altered mental status, poor blood pressure, chest pain, shortness of breath, then they will oftentimes be cardioverted electrically. So we will use our defibrillator set up in a very special way. We'll usually use a lower energy level, and we will synchronize those shocks so that it coincides with the patient's normal cardiac rhythm, and we will electrically cardiovert them. But we reserve that for patients who are grossly unstable. And this is a rhythm you almost certainly see on testing. You almost certainly see this when you do ACLS, is they will talk about this rhythm and the distinction between stable and unstable patients as far as treatment. And here's this is a 12 lead, obviously from, I'm going to go on a limb and say it's Germany, where the patient had a really, really fast SVT. And so if you want to take a second, using one of the methods we talked about before, you can see these QRS complexes are one big block apart. So that makes this rhythm about 300. So that's really, really fast. And depending on, he would need some treatment, whether he is stable or unstable. It would just depend on what that is. Atrial fibrillation is exactly what it sounds like. It is the fibrillation or the unorganized wiggling of the atria so that they don't produce a good, crisp contraction. So looking at the rhythm itself, the rate is variable based on the ventricular response. So how many QRS complexes you have is going to be, which determines your ventricular rate, is entirely based on how fast those atrial responses are conducting down to the ventricles. So while you may have a ventricular rate, anywhere between 60 to sometimes up to 300, your atrial rate is going to be anywhere between 300 and 1200 depolarizations a minute. And this is entirely based on where it's coming from in the atria, how many irritable places there are, and what this looks like. Atrial fibrillation chronically, and we have a lot of people who have chronic atrial fib, is a pretty debilitating condition. These people either end up with just limitations on their activity based on their rate, or they also have limitations on their activity based on the medications they take, because it takes a lot to get this under control. And as such, a lot of hospitals have pretty much declared war on atrial fib because it is such a thief of life in terms of quality of life and the things people can do with it. So people really work hard to try to get this under control and get it fixed. And there's also some other systemic problems that go with this. But just getting back to the rhythm, so that rate is based on how well you control the conduction into the ventricles. The QRS complex is typically narrow unless you have just really, really odd conduction through the ventricles. So it's not uncommon to see atrial fib that gets really, really wide QRS complexes as the disease progresses. But one of the things that is really important about atrial fib is the rhythm. And because of the way atrial fib works, and I got a couple of pictures I'll show you in a second, is atrial fib is grossly irregular and is the only rhythm that we're going to look at that is grossly at a baseline irregular all the time. And that's based entirely on how many of those conductions from the atria get through to the ventricles. Because this is not originating from the SA node, you don't really have P waves, you have what we call fibrillation waves. And sometimes it just looks like a flat baseline. You don't even see that many really waves down here in our example. But again, the most important thing is the irregularity. And because it's irregular with no P waves, you don't have any PR interval. These are a couple of pictures I wanted to use to give you some context about why atrial fibrillation is such a pain and why treating it is so difficult and so important. Typically, atrial fib comes from the area around the pulmonary vein. So that's right up here in the left atria. And this, of course, is a diagram of a heart. What you see on the left, on the right over here, this is an actual 3D atrial map that was done during a procedure to correct somebody's atrial fib. So this structure here, this is the left atria, and these four things right here, as you might imagine, are the pulmonary veins. And that's typically where these errant impulses that cause atrial fib come from as the heart becomes diseased. And what you see here, these little pink dots, that was areas where they burned out the fibrillatory areas to correct this patient's atrial fib. And you can see they had to do that in a lot of places. And this particular procedure essentially draws a big maze called the maze procedure, where they draw a big maze around those places so that those impulses may still fire, but now once that area is burned and then develops scar tissue, those impulses can't conduct out of there and down to the ventricles anymore. And so with a procedure like this, somebody can get off of the medications which may be limiting their daily activities. But when we think about atrial fib, those impulses as they come out of these areas up around the pulmonary veins, that's what's conducting down through the AV junction and down to the ventricles. And typically the treatment for atrial fib is about controlling that conduction through the AV junction. So they use medications like cardizem and digitoxin, or rather digoxin, not digitoxin, to control the impulses that move through the AV junction so that the heart can actually handle that. Because what happens is that if too many of those impulses get through, then the ventricles start contracting really, really fast, and the faster they contract, the less time they have to fill. And so if they can't fill, they can't pump any blood, your stroke volume goes down, your cardiac output goes down, and those patients will decompensate rather quickly. And so that becomes a real issue with treating atrial fib. And the treatment for atrial fib is very similar in degree to the way we talked about treating atrial tachycardia or SVT. It's all about stability. If somebody is grossly unstable with a really, really rapid atrial fib, we treat it the same way as we do for SVT, and that's with an electrical cardioversion, because the same thing is happening. The heart's just beating too fast, it can't fill, and they don't generate any cardiac output. And so we make those decisions based on the same criteria. Another systemic problem with atrial fib, and you may hear it talked about a lot when people who are on atrial or who have atrial fib, they're also on anticoagulants or blood thinners. And that's because when the atria don't contract normally or regularly, if they are at a standstill or areas of the atria don't move, they start to build up clots. And this is the inside of the right atrial wall from that pig heart, the same one we cut open several slides ago. And you can see in this in the atrial wall, the mural, there's a lot of little divots and nooks and crannies. And if this thing doesn't move and contract the way it's supposed to, clots will form in there, and they'll just sit there until the atria does in fact contract normally one time, and then they'll shoot out of there basically like a bullet out of a gun. And they'll get sent into systemic circulation where they may end up in the lungs and become a pulmonary embolism. They may end up in systemic circulation and become like a deep vein thrombosis. Or one of the worst case scenarios is they get shot out of there and end up in one of the carotid arteries, make its way up to the brain, and turn into a stroke. And so that's why people who have atrial fib are at also increased risk for strokes and other kind of blood clots. And so part of their medication regimen not only is something to control their ventricular conduction, it's also something to help decrease their clotting so they don't develop these clots in the atria. And that's why this is just such a nasty, nasty condition, and why we work really, really hard to fix it. Somewhat similar to atrial fib is atrial flutter, with the main difference is the appearance of those waves between the QRS complexes and the regularity. Typically the rate, depending on how well controlled it is, can be similar to what you see in atrial fib. So you can have a very well controlled atrial flutter, which will have a normal heart rate somewhere between 60 and 100, or you can have wildly uncontrolled atrial flutters, which are much, much faster. And the faster they get, the more they start looking like the SVTs or atrial tachycardias. Only when they get slowed down and well controlled, like the one you see down here, can you really see the flutter waves. And the flutter waves differ from the fibrillation waves, and they seem to have some structure. They're often referred to as sawtooth waves or sawtooth tracings. And if they are conducted regularly, in other words, this one has a this is a 3-to-1 conduction. So there are 3 flutter waves for every QRS complex. When they're conducted this way, they're pretty regular. And if they're conducted this way and ventricular conduction is normal, then the QRS complex is also going to be kind of narrow. So in that way, it looks somewhat normal. The difference again is that you don't really have P waves. You have these flutter waves. Sometimes the EKGs will pick up these flutter waves as P waves, so it may measure a PR interval, but that's not going to be clinically useful for you. And treatment for this is going to be very similar to atrial fib. If it's asymptomatic and it's well controlled, it may need none. If it gets too fast where the ventricles can't fill, then you may need to do some sort of cardioversion, whether that's with medicine or with electricity. So shifting a little further down from the atria, we now look at junctional rhythms. And junctional rhythms occur in the AV junction, or the AV node. So what's happened here is, for whatever reason, the atria and the intranodal pathways and the SA node are now no longer the default pacemaker for the heart, and that job is now fallen to the AV junction. So these rates tend to be slower just based on the intrinsic pacemaker speed of the AV junction, usually about 40 to 60 beats a minute. If it's greater than 60, we tend to call that accelerated junctional. That's an academic distinction, but it may be something you see on a test where you'll see a rate or a rhythm which meets these other criteria, but it's just faster than what you normally see. Because it's still above the ventricle, the QRSs tend to be still within normal range. However, they tend to get a little wider the further down you go. The rhythm is usually regular, and you will usually see either, the most common thing is to see no P waves. You may also see the inverted or biphasic P waves. You typically won't see a rounded upright P wave, because if you did, that would make this a sinus rhythm. And the PR interval is going to vary based on if you actually have P waves or not, and whatever they look like. Treatment for this will usually be based on the rate. If it's too slow, you'll need to do something to speed that up. But that's usually uncommon. The most important thing here is to recognize that it's not a sinus rhythm just based on the idea of those P waves. Another junctional finding you may see is premature junctional contractions or complexes, very similar to what you saw with premature atrial contractions or complexes. The difference is they will be maybe a little wider, and they will have either no P wave or the ugly upside down P wave. Sometimes it's real hard to tell the difference between these and PACs, and fortunately usually that distinction doesn't matter. This just may be something you see that would show up on a test or a comp one day. QRS is usually normal. The rhythm is going to be regular except for that ectopic beat in the pause that follows. P waves will typically be normal if they are normal for the intrinsic rhythm. They'll just be absent on the ectopic beat. And the PR interval for the underlying rhythm should be normal. These also, again, just like PACs, usually don't require any intervention. In addition to the accelerated junctional rhythm would be the junctional tachycardia. This would be obviously greater than 100 and usually around 150, maybe a little higher. And these look a lot like the atrial tachycardias. So they tend to be pretty fast with a narrow QRS complex, no real P waves that you can see. And a lot of times they're almost interchangeable. You can't really tell the difference. Rhythms are regular. The P waves are usually absent. They may be lost in there somewhere if the rhythm's really, really fast. Usually they're not there at all. And if they are there, then the PR is going to be variable. But again, you're not going to see the P waves. And you're going to treat this the same way you would treat the other tachycardias. As they get faster and faster and faster, the patients become unstable. You would cardiovert them with electricity. Otherwise, they may need a specific medication to convert that into a regular rhythm. History is really important with patients like this, and that's also true of the other tachycardias we looked at, to see if this happens to them normally or happens to them a lot, or they've had this before, maybe in relation to a heart valve problem or to an old heart attack. So to review, the atrial and supraventricular rhythms, they tend to originate in the atria or the AV junction, not the sinus node. QRSs tend to be normal duration unless there is some sort of secondary conduction problem down in the ventricles. The rhythms are variable based on the factors we've talked about. They do have P waves. They're not going to look normal. They're going to look upside down or biphasic. Usually, especially the further down you get in the atria down to the AV junction, usually the P waves aren't there at all. And PR intervals are going to be variable, again, based on the things we talked about. And what you call them is going to vary according to the rate. But you can look, especially as you get further down toward the junction, if it's not tachycardia, you can expect those rates to be slower because now the AV junction has taken over as the pacemaker at its intrinsic rate. And that brings us to ventricular rhythms. Now, as the name would imply, they originate in the ventricles. Now, something that's inherent to ventricular conduction is if the rhythm originates in the ventricle, then its conduction is going to be rather unusual. And the biggest sign of that is going to be wide QRS complexes. So it's going to be greater than 0.12 seconds. And we talked about that earlier when we talked about depolarization and repolarization and what the different waves meant. And I briefly mentioned there that when you hear the word depolarization, you should think of contraction. Well, when you hear the term prolonged depolarization, then what you should be thinking of is wide QRS complex, because the longer the depolarization takes, the longer it's going to take for that impulse to move throughout the ventricles and cause the whole thing to contract. The longer that takes, the wider the QRS complex gets. So that's going to be your hallmark for your ventricular rhythms. Now, usually the underlying rhythms here are usually going to be regular. That will be especially important when you talk about VTAC. Because they're ventricular, if it's a totally ventricular rhythm, then you're not going to have any P waves because the SA node is not participating. There'll be times where you see P waves, but it won't have anything to do with the QRS complexes. And because of that, you're not going to have a PR interval to measure. And what you call these rhythms and their effect is going to be based a lot, again, on the heart rate. So the first thing we'll start with is the ectopy. So premature ventricular contractions, or PVCs. You may hear people talk about these a lot. There's been a pretty big shift over the last 20 years or so about what we do with PVCs. And what we do with PVCs now is not a whole lot. We used to treat these pretty aggressively with drugs and some other interventions. And we found that to be largely unnecessary. The value of the PVC is its clinical indication that something else is wrong. Usually what a PVC is telling us is there is some kind of ischemia somewhere in the heart. So PVCs are relatively common with certain kinds of heart attacks because you have a big ischemic area in the heart, and one of the ways that your heart protests against being ischemic is that it starts depolarizing certain places before others and spitting out these ectopic beats. Now, the ventricles being the biggest chambers, they're the most likely to be prone to this. So when you look at PVCs, these are going to be superimposed on whatever the underlying rhythm is. So if the underlying rhythm is regular, then it's going to be regular, and we're going to have the PVC on top of that. So you'll see down here, excuse me, we have a underlying sinus rhythm. That are these little beats right here. Now you should P wave, QRS complex, and then the T wave. And then next to that, we have these big, ugly, wide, unusual looking beats. Those are your PVCs, and what sets them apart from PACs or PJCs is their width. So these big, ugly things. Now, you don't need to be concerned so much if they are right side up or upside down compared to the rest of the rhythm. That's going to mean something, but it doesn't in terms of this. What you're really looking for here is how wide they are and where they occur. So we'll see some other examples. So we look here, and sometimes you'll see other words used in conjunction with PVC. So up here you see unifocal PVCs, and you can see a couple of examples. And you'll see here are the ectopic beats. And what they are, what unifocal means is they're coming from the same place. Where if they come from the same place in the heart, then they look alike from beat to beat. So this one is shaped the same as this one over here. And in between that, we have our regular normal sinus rhythm in the middle. Over here, or under here rather, we have a couplet of PVCs. So here we have our underlying normal sinus rhythm, and then we have two big, ugly, wide beats that look the same that happen one behind the other. So that's a couplet of PVCs. That's two together. Couplets differ from what we call bigeminy, whereas couplet PVCs occur together. Bigeminy occurs alternating with the underlying rhythm. So here you see we have a regular sinus beat and then a PVC, a sinus beat and a PVC, a sinus beat and a PVC, and so on. So you'll have periods where they have bigeminal PVCs that may go on for a long time. You may just have a short run where you have this, but when you put those together like that, that's what it looks like. It's every other versus couplets, which are those in a row. You can also have trigeminy, which is a PVC every third beat, a quadgerminy, so on and so forth. You can aim that pretty much out as far as you want to. The clinical significance of those becomes less and less. At the top, you have multifocal PVCs. So you'll see a sinus beat, a PVC which is upright, a sinus beat, and then a PVC which is kind of inverted. And the important part about this is the PVCs look different. And this is decidedly more problematic than the unifocal PVCs, because the multifocal PVCs mean you have more than one place, more than one irritable focus that is causing you problems. So somebody who has multifocal PVCs is probably a little sicker, maybe has a wider spread of ischemia than somebody with unifocal PVCs. In comparison to the couplet, we look at a triplet, and all that is 3 PVCs in a row. And they are usually unifocal in nature because they come from the same place, and that's one spot down there which is now spitting out multiple depolarizations in a row. Usually if you get any more than 3 together, that becomes VTAC, which we'll talk about in a minute. So unifocal, single PVCs coming from the same place. Multifocal, PVCs coming from multiple places. Couplet, 2 PVCs together. Triplet, 3 PVCs together. And bigeminy is alternating sinus rhythm or underlying rhythm, PVC, underlying rhythm, PVC. So if the ventricles take over as the primary pacemaker, you get what we call an idioventricular rhythm. Sometimes you'll hear this referred to as a ventricular escape rhythm, and when you hear escape, what that means is that the primary pacemaker has failed, so the next pacemaker has stepped up. So you can have a junctional escape rhythm, you can have an atrial escape rhythm, and more commonly you have idioventricular or ventricular escape rhythms. Since we remember our intrinsic rate for the ventricles is between 20 and 40 beats a minute, that's usually going to be our heart rate. You also hear this called an agonal rhythm. That's usually a little slower. If it gets greater than 60, then we would call this an accelerated idioventricular rhythm. And that's no less troubling, but maybe a little less deadly in the short term. Again, the hallmark of ventricular rhythms is wide QRS complex. Every QRS complex is going to be greater than 0.12 seconds. The rhythm should be regular. It may vary in speed, but typically it's going to stay regular. No P waves because this is a ventricular rhythm, and of course, no P wave, or no PR interval, rather. An important thing to remember is that you may have occasional P waves. Every now and then the sinus node may depolarize and will spit out a P wave, but that typically doesn't conduct at all because the ventricles have taken over this rate. So you don't need to let a single little P wave here and there distract you from what's going on. Down here at the bottom we have examples of both. Over here we have the idioventricular rhythm, so it's really, really slow, and then we have the accelerated idioventricular rhythm, which is a little faster. You can see these look very similar, big, wide, ugly QRS complexes. These both just happen to be inverted. Depending on what lead you're in, it may not be true, but in lead 2, these both happen to be downward-facing QRS complexes. And the treatment for this is going to be based on symptoms. So you may have a patient who may have no symptoms at all for this and require just observation until it's time to do something, until they decompensate. Other patients you may find who may be peri-arrest. They may be about to die with this rhythm. And so speeding it up for them is going to be of paramount importance, and also treating whatever's causing it. A lot of times rhythms like this are associated with structural defects in the heart or heart attacks, probably most commonly. You can also see rhythms like this with certain kinds of electrolyte imbalance. And so understanding what those things are and correcting them is the usual key to fixing these. Ventricular tachycardia, I can guarantee you this is going to show up on a test somewhere, probably a number of tests somewhere before you're done with school. Because it's one of the most common lethal arrhythmias you're going to see, and it's one of those things which is never normal and somebody's going to die if it doesn't get fixed. Because it is tachycardic, it is rate greater than 100. Typical range for VTAC is going to be between 120 and 180. It can be higher than that, it can be lower than that, but usually that's where it's going to live. QRS complex is going to be wide. It'll be very evident when you see it. Now, an important thing about this is that unless it's acted on by medicine or electricity, VTAC is going to be regular. Now, this is important when you compare it to if you have somebody who has atrial fib. And atrial fib with other kinds of conduction abnormalities may look wide, and it's going to be fast, and so it looks a lot like VTAC. And so we can actually spend a lot of time, and there's a lot of criteria you can apply to deciding if somebody has VTAC versus what we call atrial fib with aberrancy. For the purpose of this, just pay attention to the one single lead and pay attention to the criteria. You're going to get both handouts, both for the rhythm analysis class, which is basically what this is, and for the basic 12 lead. In the basic 12 lead handout is a section on VTAC, or wide complex tachycardia, and how to tell the difference if you really want to dig into that. But regular rhythm, no P waves, no PR interval. It's going to be fast, wide, and regular. That's really your hallmark for VTAC: fast, wide, and regular. The treatment for this is going to be based on, again, stability. You can have somebody, believe it or not, with VTAC with a pulse, and they may even be stable. If they have a pulse and they are stable, which is pretty rare, they may try medication with them first. There are several different kinds of medications, like amiodarone and lidocaine, which act on the ventricles and may slow the rate down. Usually these patients are going to require some level of electricity. If they have a pulse, then we will usually do what we call a synchronized cardioversion. We talked about that briefly with SVT earlier. So use a lower energy level and you will synchronize so that the shock falls on the R wave or the QRS complex. And what this does is it terminates the underlying rhythm with the hopes that it's going to allow the patient's normal conduction system, the SA node, to take back over and establish a normal heart rate. If you have somebody with VTAC without a pulse, in other words, they're in cardiac arrest with no pulse, they're unresponsive, then you're going to treat them just like you treat VFib, which we'll talk about in just a second, and they're going to get defibrillated and they're going to get CPR. And you will go into that when you did that in BLS, and you'll go into that much more when you do ACLS. So ventricular fibrillation is really kind of the worst of the worst. Another one I guarantee you're going to see on the test, on a test, probably many tests before you're done. You talked about this in BLS. When you got your BLS certification, you'll talk about this at length in ACLS. And it's just this big, nasty, gnarly, squiggly line which signals complete disorganization of ventricular activity. So there's no rate, there's no QRS, there's no rhythm, there's no P wave, there's no PR, there's nothing but this just squiggly mess. Now P wave or VFib can vary in its intensity. You can have coarse VFib, which is kind of what you see here, and then you can have very fine VFib, which is just very little variation from the baseline. The underlying cause is probably the same. Usually this is caused from ischemia secondary to myocardial infarction. That's where you're going to see it the most. And the treatment for this is defibrillation and CPR, and repeat as long as it's there. So when you learned BLS, the way we treat this in ACLS isn't going to be a lot different. You're going to do very good CPR, make sure to keep that compression rate up, and then every 2 minutes doing the rhythm check and defibrillating if it's time. There are things we're going to do to try to get them out of this rhythm as far as from a medication standpoint, but there really is no substitute for good CPR and defibrillation. So, and the caution I would give you here when looking at VFib, especially when you're doing testing, is apply these criteria every time. Every VFib is not going to look like what you see on the screen now. Some are going to be much smaller, some are going to be bigger. What you're looking for is that lack of rhythm and lack of everything else that you've been looking for, and that's going to point you toward VFib. This is another one in the academic department, ventricular standstill. If you look at these, you will see these are fairly regularly spaced P waves and nothing else. And these come from the P wave, or the SA node is still working, but nothing else is. And so this patient's trying to conduct, his SA node is still firing pretty regularly, and just nothing's happening. This is pretty uncommon. These patients go to asystole or VFib usually really fast. And this is usually just gross ventricular dysfunction. Their ventricles don't work anymore. So you can see everything is pretty much absent except for the P waves. You can't measure a PR interval because there's nothing to measure it against. There's no R to measure the P against. But otherwise, the atrial function looks pretty good. Also, this doesn't last very long, and if you're looking at this too long without doing CPR, you're doing something wrong. So to recap, ventricular rhythms, remember the hallmark of these when they originate in the ventricles is that wide QRS complex. So everything about these is going to be wide. And that's going to help you to differentiate between these and the other rhythms that we've already talked about, is that because that conduction through the ventricles is kind of backwards, it's going to widen that QRS complex. Usually the rhythms are regular, unless, cases like VFib or the PVCs, which are going to throw off the rhythm a little bit. In the ventricular beats, then you're not going to have any P waves or PR interval, and what you call it and what it looks like and basically how you treat it is going to vary entirely based on the rate. Now we're going to kind of circle back up and look at AV blocks, and we do that separately from the SA node and the atrial rhythms just because I want this to stand out by itself. And that what you have here is exactly what it sounds like. You've got a conduction disruption between the atria and the ventricles. And so you may conduct normally out of the atria. In other words, you may conduct a normal sinus beat down to the AV junction, and then something's going to happen there. It's going to be lost or delayed, and that's going to cause the rhythm to be unusual. So the atrial rate is usually normal in these cases, somewhere between 60 and 100. The ventricular rate, however, is going to be variable based on the conduction. So we're going to have different degrees of heart block, and that's going to change how the ventricular rate responds to that, which is going to change the overall heart rate out of the ventricles. The duration of the QRS complex depends on the type of block. So if you have a QRS complex which is completely blocked from the atria, then it may be very similar to a ventricular escape beat where it may be wide. Otherwise, that may look kind of normal. It depends on how complete that heart block is. The rhythm is usually going to be grossly regular except for the parts which are affected by the heart block. And believe it or not, the more regular it is, the worse that is, because that means that you have dissociated from the atria and the ventricles completely. The P waves themselves usually look pretty normal. They just may not be related to the QRS complexes. So you're going to have variable PR intervals till eventually you have no calculable PR interval at all because they're not related as it gets worse. The heart blocks are going to be graded first, second, and third degree. The higher the degree, the worse the block. So we'll start with first degree AV block, first degree heart block. You'll hear it called a number of things. Typically the atrial and ventricular rate for this is going to be the same because these are actually conducting from the SA node down through the AV junction to the ventricles, just a little slower. So the QRS complex should be about the same width as it normally is. The rhythm will be regular. The difference is, and the P waves will be normal, the difference is the PR interval is going to be greater than 0.2 seconds or 200 milliseconds. So you see our example over here. Here we have the previous QRS complex. The T wave right behind the T wave is the next beat's P wave, and then we have a big long PR interval. So there's 200 milliseconds or 0.2 seconds, and then there's 1, 2, 3, 4. So the PR interval for this is almost 0.4 seconds, so almost twice as long as it should be. And you see this is persistent, so the rhythm is regular, and every QRS complex and every P wave looks the same. Typically first degree blocks don't cause a problem if they happen by themselves. Sometimes they are idiopathic. That's a word you should learn. Idiopathic means we don't know why it happened. A lot of times though, what they're finding now is that first degree heart blocks can be secondary to medication or toxicity. So like if somebody takes too much beta blocker, like too much low pressor, then they can have a first degree heart block. First degree heart block with other kinds of conduction blocks can also be pretty troubling, but by itself, first degree block usually doesn't need any kind of intervention. You just need to recognize that it's there. Second degree heart block is broken into two types. They call it Mobitz type 1 and Mobitz type 2. Mobitz type 1 is also called Winky-Bach phenomenon, and it relates to the way that the variability of the conduction of the P waves to the QRS complexes. So in these, the ventricular rate is typically still normal, about 60 to 100. The atrial rate is slightly faster only because you have extra P waves that are not conducted. QRS complexes tend to be narrow or normal. The rhythm is what we call regularly irregular. In other words, it's predictably irregular, whereas with atrial fib, it was irregularly or unpredictably irregular. And the reason why this is predictably irregular is because every few beats, you're going to see where the PR interval is going to get longer and longer and longer until finally you have one that fails to conduct. So that is the hallmark of second degree type 1 or Winky-Bach, is PR interval gets longer, longer, longer until it drops. That's why it's so important when you're evaluating these patients or when you're taking a test that you take plenty of time to look at these rhythm strips from beginning to end. Because if you were only to look at the first couple of beats right here, you may be inclined to say that was normal because the PR interval is not all that long. It's a little different, but maybe it's not that big a deal. Or if you only looked at these two, you may be inclined to call it just a first degree block because you didn't look at the whole thing. So if you look at this rhythm strip from beginning to end, you see the PR interval gets longer. On the second beat, longer still. Third beat, longer still. Fourth beat, it just isn't there. You have a P wave and then nothing else. And then the rhythm, it starts over again. And what this is, clinically speaking, is a AV junction which is getting progressively sicker. And so you have a pathway in there which has a very regular rate of conduction and a regular delay of conduction. So that's why you get this PR interval which is normal, then it gets longer, 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 and drops. So that is second degree type 1. Now that we're going to contrast that in just a second with second degree type 2. So second degree Mobitz type 2, which doesn't have a fancy cute name like Winky-Bach, it's mostly the same as far as the criteria. So the ventricular rate is still going to be somewhere between 60 and 100, usually normal. The atrial rate is going to be a little faster because you're going to lose some beats. And the rhythm is also going to be predictably irregular within itself. The P waves themselves are usually pretty normal, but the difference in this and type 1 is now the PR interval is usually going to be constant. So it's usually going to be constant. It's usually a little longer than you see in this example here, so it's usually almost a first degree block at a baseline. But then every so often, and you see this one is pretty regular, this is a pretty severe second degree heart block. And you'll see that only about every third P wave results in a QRS complex. So here you see a normal impulse, P, QRS, T, immediately followed by a P wave, nothing behind it, another P wave, nothing behind it. The next P wave gives you a QRS complex, and that repeats. And that's going to be variable, but the way you compare this to type 1 is type 1 you have a variable PR interval, so it gets longer, 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 then it drops. In type 2 you don't have that. All you have is the normal PR interval, or slightly longer, but it's constant for all the ones that conduct, and then you have those just completely missed beats. Second degree type 2 is typically viewed as being worse than type 1, because what's eventually going to happen if this goes untreated or left unchecked is eventually these conducting beats will also stop conducting QRS complexes, and then it will become a complete heart block, which we'll talk about in just a second, where the P waves and the QRS complexes don't have any relationship whatsoever. And that brings us to third degree or complete heart block. Complete AV block can be called any number of things. Most important thing here is that the P waves and the QRS complexes don't have anything to do with each other. Now, how you figure that out is typically you can take the P waves and you can march those out. And I say march those out, you can space them out one to the next, and their rhythm will be constant. In other words, the P wave rhythm will be the same. P wave to P wave is going to be the same. And then you can do the same thing for the QRS complexes. The QRS complex will be regular to the next one to the next one. Now usually this rate is pretty slow because usually that is a ventricular escape beat, and we know those are pretty slow. So, but the most important thing here is they don't have anything to do with each other. Now if these get fast, like if you have a faster escape rhythm, then they become a little difficult to tell the difference between these and, say, like a second degree type 1, because it almost looks like there's some relationship when there may in fact not be. You just have to evaluate those patients clinically, and whenever you're looking at this in testing, they typically don't make those examples very difficult, so they aren't trying to confuse you with that. But the rate, again, is dependent on what the escape rhythm is. The atrial rate is usually normal, 60 to 100, whatever the sinus rate would be. The width of the QRS depends on where that escape rhythm comes from. If it's a ventricular escape rhythm, then it's going to be nice and wide. This is actually a junctional escape rhythm, so it's a little more narrow. The rhythm is usually regular, P wave to P wave and QRS to QRS, and there's really not a PR interval that, by technical definition, because those two things aren't put together. Treatment for any of the heart blocks is usually symptomatic. So obviously the sicker patients are usually going to be the third degrees, and they may require something to increase their heart rate, or they may need to be paced. A lot of times we may encounter patients who have third degree heart block or complete heart block, which is new onset, and they have no symptoms whatsoever. Matter of fact, you'll find them, they'll be perfectly fine, their mental status is great, they're warm and dry, and they may even be hypertensive. In other words, their blood pressure is high, and they don't require any immediate intervention. But those people do need intervention. They're probably going to need a pacemaker, because likely once this happens, it doesn't usually resolve without some kind of intervention. And so if we find them, a lot of times we find them by accident, by doing some other kind of screening, and see their heart rate's really low, and we start working them up, and that's what usually gets them in there to get a pacemaker. And finally, you can't talk about rhythms without talking about no rhythm, and that's asystole. And really, asystole is the absence of electrical activity. Most important thing when you encounter someone with asystole is, first, when you look at them, and if they're talking to you, they do not have asystole. Most likely they have a machine malfunction, they have a lead off, something like that. But if you encounter somebody who's in cardiac arrest and you first put them on the monitor and you see that they have no electrical rhythm, you're then going to make sure that all your wires are connected, all your leads are stuck on, everything is like it's supposed to be, and then figure out that they actually don't have any kind of rhythm. It won't always be flat like this. They describe asystole as being flat line. It won't always be like that. Sometimes it'll kind of have a wavy baseline, especially like if they're in the middle of a resuscitation and somebody's breathing for them. You may see some variability on that based on the diaphragm, as the breath's going in and out and it's pushing these electrodes. You may see it get kind of wavy, and it may be wavy at a baseline without doing anything. But the most important thing is you don't see any of the normal characteristics you would see in a perfusing heart rhythm. And you may also see this may be confused with a very fine V-fib. And so one of the ways you can isolate that is to just have everybody stop touching the bed, get away from the patient, and just look for a second with nothing else going on to see if they truly have any electricity or not. There's a whole branch in the ACLS algorithm that talks about dealing with asystole. These people, they don't get defibrillated. They do get good quality CPR for as long as you're working this, and they get treated with the same kind of drugs. The difference is asystole is usually a terminal rhythm. In other words, we've done all the resuscitative things and nothing has worked, and so this may be the end. And typically one of the criteria for stopping resuscitation is prolonged asystole. Just a real quick word about pacemakers. We could literally spend a semester talking about nothing but pacemakers. Now, relax, we're not going to do that. But there are so many different varieties of pacemaker. The pacemakers do different things. They are put in different chambers of the heart. They activate in different ways. They may be demand. They may be fixed. They can just be all different kinds of things. The characteristics of pacemakers, however, first of all, you should have some idea they have a pacemaker before you ever get to the point of doing an EKG. So if you're putting EKG leads on and you see a big lump under their skin, usually on the left side of their chest, that's usually a pacemaker or a implantable defibrillator unit. And so that's usually a dead giveaway that they have a pacemaker. You should also see it in their history and things like that, which will help you explain what some of the rhythms you may see. And I just put this on the screen here. We're not going to dig into this at all. Just to say, one of the things that sets pacemakers apart from other rhythms, regardless of anything else they look like, is the presence of the pacer spike. And the pacer spike is the actual impulse from the pacemaker which generates the rhythm. So this is a AV sequential pacemaker, so it has an atrial spike and a ventricular spike. This one is very similar to that. You have spikes here. This one has spikes here and an otherwise normal-looking QRS complex. This is a more common old-school pacemaker where you have a pacer spike and a big, ugly ventricular rhythm because that's where the wire is. Again, really the only reason I want to bring this up without digging into this too much is just understand that when you see these big, ugly rhythms like this, one of the things you probably want to look for is to see if it has a pacemaker spike, because that's going to lead you that regardless of whatever else this is a pacemaker rhythm. Well, that covers all the basic rhythms that you need to know. One quick thing is, if you want to truly understand EKGs and you want to really master this, you've got to have EKGs in your hand. You have to be looking at these things every single day or very regularly. And I always equate this to people who have to tie knots for a living. So if you have to work with rope and tie knots, nobody's born knowing how to tie a knot, and so you have to learn how to do that, and then you have to keep doing it so you don't forget it. Reading EKGs is the same way. Even being proficient with the rhythms is the same way. If you want to be able to do this and do it well, you have to have EKGs in front of you all the time so you can practice and get better. One of my favorite resources for doing this is the ECG Wave Maven. So if you just Google that, ECG Wave Maven, the URL is actually pretty long. It will get you right here, and you can go to where it says Browse the Case List, and it's got, last time I looked, it's a little over 400 EKG cases broken up by severity and by complexity. So it has like 1 star for difficulty versus up to 5, which is really hard. But it shows you the EKG. It walks you through the case. There are several examples where they have video from the cath lab and video from the echo and from the heart or from the nuclear medicine scans and things like that to back up their diagnosis. So you can not only see what the EKG looks like, you can also see everything that went into making that diagnosis. That is truly, truly good for learning if that's what you want to do. Also, again, you're going to have the copies of the handout for the rhythm analysis class and also the copy in the handout for the basic 12-lead class. If you run into any problems, have any questions, you can give me a call. There's my email, there's my phone number, you can call or text. Thank you and good luck.